Inequalities matter, and you have the power to change it. Inequalities matter, and we have the power to change it. I'm Kevin Fenton. I'm the Public Health Director for London, and I've been in this role for 3 years. It is a privilege to be the Public Health Director for this wonderful city. I've had the privilege in my career of being involved in different pandemics, different challenges which affect the health and well-being of our communities. I've practiced in the Caribbean, I've practiced in the US, I've practiced in Europe, but I call London home. It's been a privilege to lead the city of 9 million people through the COVID-19 pandemic. And the story that I'll tell you tonight is a story of what we've learned in the pandemic and how the pandemic experience has transformed each of us and will continue to transform this city. So, let me tell you a little bit about myself. I was born in Glasgow. Any Regis here? Anybody here from Glasgow? Yes! Fantastic. But raised in Jamaica, and I did all of my undergrad training in Jamaica, and I came back here to do my postgrad training in London. And it's been a real privilege to work on cities of import to London. My first pandemic was the HIV/AIDS pandemic, and in fact, it's probably the reason why I chose medicine. I will never forget when I was only 14 years of the first cases of AIDS, which was then to be called AIDS, that were diagnosed both in New York and San Francisco in 1981. And many of you who were around at that time, and I'm loving the age diversity in the room, so for those of you who weren't here then, this is an important story. Because when those first cases were diagnosed, many of you will remember the fear, the stigma, the othering that occurred at that time, the loss and the pain that signified the beginning of that pandemic. And as a 14-year-old, I remember saying to myself, I want to be part of helping to solve this problem. I want to be part of helping to change this narrative. I want to be part of understanding why are some people more affected by some diseases than others. I wanted to be a part of bringing together science and hope and joy and an experience that says, actually, you can make a difference in this world. So, the story that I'll tell you tonight is a story of transformation. It's a story about what we're learning about health inequalities in London. It's a story of the journey that we've been through in the pandemic, but also what London was before the pandemic and how we will continue to change and evolve. Now, transformation is going to be a key theme of this lecture today. So the first thing I'm going to ask is for you to think about how has your experience of going through COVID-19 changed you? How has the pandemic changed you? And it's really important that we think about the 3 years that we've been going through. Because it's so easy to go back to normal, isn't it? The clubs are open, the bars are open, we're going out now, we're not wearing masks anymore. But we should stop and think, reflect about how we've changed. So, first task for you this evening, I'm going to ask you just to spend 15 seconds on your own. Just thinking, how have you changed? I'll share with you how I've changed. And then I'm going to ask you, after 15 to 20 seconds, to turn to someone on your right or to your left and share. How have you changed as a result of going through this pandemic? And then after that, for those of you who are brave and you'd like to share with the entire auditorium, I'd love to hear your story. And I'll share mine. So let's do this. 20 seconds on your own. How have you changed as a result of going through the pandemic? Great. Now, person on your left or your right, whoever you feel comfortable sharing with. Sometimes you may be in a group of 3. Just share your story. How have you changed? Okay, thank you. Thank you. Thank you. Thank you for sharing your story. Thank you for reflecting with me on how you've changed. So, how have I changed? Well, first, the pandemic stopped me clubbing, which I'm still sore about. But I had one of my joys in life is dancing. I don't know if there are any other dancers in the room, but I love dancing and being in rooms with thousands of people having a great time. And that stopped as a result of going through the pandemic. Please don't tell my bosses this, by the way. But on a serious note, the pandemic did three things for me. First, it helped me to reconnect with what's important in life. And that was really important as we went through some of the darkest days of the pandemic, when we were working, and many of my colleagues from the NHS are here, and I want to just acknowledge the leadership and support we had going through the pandemic. It was getting that sense of what's important, realizing that partnerships and strong partnerships and friendships and colleagues will be what gets us through. And third, I learned about the resilience that I had, which I didn't know I had, to the depth in which I discovered in going through that experience. And I'm intent on holding on to that. So, anybody want to share? I have time for 3 people to share, starting on this side. Anybody here would like to share? What's your story of change and transformation in the pandemic? Yes. Vincent?
Before the pandemic, I would leave the house before the kids woke up, come home after they've gone to bed, 5 days a week, and not really realize that you basically don't see them 5 days out of 7. I'm definitely not doing that anymore.
Exactly. So again, what's important to you? The story here is a story of a father, perhaps not prioritizing connecting with their children, but the pandemic and the time that it allowed you to do that. So that story of personal connection. How about this side? Thank you. How about this side? Who wants to go? Yes, please. If you could just project your voice so we can hear.
So, the big thing for me was just looking for credible sources of information and becoming much more aware that social media had some good information, but it had an awful lot of misinformation.
Yep.
So you had to be really careful about what you believed and what you didn't believe.
That's right. And in fact, myths and misinformation, whether passive or actively distributed, have been a key feature of what we've experienced in the pandemic, and it's been even further amplified as we've exited the acute phase of the pandemic. And with the advent of artificial intelligence, the real danger now is how do we help ourselves to understand what's truth, what's not, what's opinion, and what's fact. Absolutely, I think that was a real pivotal moment for many of us. On this side, and I definitely need to hear from a woman, great.
So I was a senior in high school when the pandemic hit.
Yeah.
It cut my senior year short completely. And that for me, I always like going to school for my friends and stuff, but it really, for my education-wise, being able to like, just getting separated from that, and it just made me gain a like wider appreciation for my opportunity to go to school and be seeing my friends every day, being with my teachers. And so, yeah, definitely just
Brilliant, thank you so much. And for me, that's a story of the everyday things that we take for granted, the simple things in life that we take for granted that we've learned to actually appreciate more. Yeah? Our colleagues, our classrooms, going out, being in the park, etc. These moments of what's important have to be a legacy of the pandemic. And thank you for joining me in just going back and reflecting. Because another legacy of this pandemic is our understanding of what causes inequalities. And there are going to be 3 key things that we'll reflect on today. The first is that equality matters, but really, if we're in the business of improving health and health outcomes, equity is also important, and perhaps even more important. Second, we will explore health inequalities in London to show how persistent and pervasive they are. We'll reflect on the impact of COVID-19 and the lessons that we've learned over the past 3 years. Lessons which I'm committed to converting into legacies for our city, so we never go back to where we were. And third, I'm going to argue that for meaningful change in completely tackling ethnic disparities that occur across racial and ethnic minorities, that if we are going to be effective in tackling them, then one of the key lessons of the pandemic is facing up to, naming, and addressing structural discrimination, which includes structural racism. So, London is home. And as I said, I've been living here now for more than 20 plus years. Let me not give you any exact figures. 20 plus years. I can see the mind thinking there. 20 plus years. And it's a fantastic place. And, we all love the city, right? It's a place of diversity, entertainment, and culture, and anonymity. You can be who you want to be in this city, but it's a city of connections and friends. And I have some wonderful friends who are here with me tonight, wonderful colleagues who are here with me tonight as well. And this is the place that I call home. However, London is also a place where it is a hard city. And it's a hard city on many, many fronts. Let's look at the data on what happens in the city, sometimes happening right beside us, but we're not aware of the inequalities and the depth of the inequalities in our city. And in fact, London has some of the highest levels of inequality in the country, in part because we have some of the richest in the country, and we also have some of the poorest in the country. 2 in 5 children in London currently live in poverty, and there's a real risk that that number is going to increase with the cost of living crisis. A quarter of Londoners are struggling to buy food and essential items. And in fact, again, with the cost of living crisis, this number is increasing and is projected to increase before we exit the cost of living crisis. We know that a significant proportion of Londoners don't feel that they're being treated fairly. And this concept of fairness and unfairness in the city from polling data has been shown to be widening as we've gone through the pandemic. So rather than thinking that we've gone through the pandemic and we are in a place where things are going back to normal, more and more Londoners are feeling disconnected. They're feeling that this city doesn't work for them or for us, and that we need something different. And that's particularly so among our Black and minority ethnic Londoners. And we know that lower income and ethnic populations within the city really bear the brunt of poor health outcomes, poor economic outcomes, in part because communities in the city have poor access to the things that generate health, right? Clean air, green spaces, blue spaces, access to water, good housing. These are the things that are fundamental in generating health. And we know that in a city of 9 million people, many of our fellow citizens are not able to access those health-generating properties of the city. And you don't have to not follow the news to see as far as populations such as gypsies and travelers, Roma people, people who are sleeping rough in the city, asylum seekers. We're seeing increasing populations of those groups, as well as increasing needs of those groups as well in the city. So London is a place, yes, of opportunity, yes, of diversity, but it is also a place where there's significant need. Now, as we go through the presentation today, you're going to see a number of quotes, and these are from some of my public health heroes. And this first quote is from Sir Michael Marmot. And I think this quote really summarizes what's happening in the city. The reality is that our health is in fact dependent on the state of our society and the distribution of power and resources in it. The distribution of power and resources in it. And nowhere was this made clear as when we were going through the pandemic and who COVID-19 affected and why COVID-19 affected different Londoners. So let's look at the data and see some of the other differences that we're seeing in the city. So although London generally has a higher life expectancy than the overall England average, so we're 80.3 years for men, 84.3 years for women, slightly above the national average. The reality is, as we've gone through the pandemic, the increases in life expectancy that we've had for so many years is now beginning to slow. And in some of our more impoverished or poor parts of the city, life expectancy is beginning to decline. And the nature of this change in the city is phenomenal. Take the Elizabeth line, as you move from west to east of the city, you see significant changes in life expectancy. And it's phenomenal that you could be living only a mile or two away in London and have completely different life chances. So in Hanwell, you can see your life expectancy is about 80 to 84, in keeping with the national average. As you move into zone 3, for those of you here who live in West Ealing, your chances of living, I'm sorry to tell you, to 82 years if you're a woman, for women, and 79.5 years for men. As you move into central London, what happens? Let's look at Liverpool Street, one of the highest levels of life expectancy in the city, in part because of the wealth that's there, in part because of the choices that people living in central London and the selection that occurs. If you're able to afford to live in central London or by Liverpool Street, you're probably doing pretty well. What happens as you move further east? And this is Whitechapel, in one of the poorest boroughs in the city. You can see the impact on life expectancy, 76.5 years for men and 81.7 years for women. And let's move further east as we go 4 miles away to Custom House. And you see the significant life differences in life expectancy. And that, colleagues, is a journey through London. And this is the inequality that we're living with, cheek by jowl, in the city. The chances for Londoners to also live healthy lives also quite different. So a healthy life expectancy is how long you can expect to have healthy lives before you develop your first major long-term condition. If you live in Richmond and Thames, you live until you're 70 years old before you begin developing a major long-term condition. Compare that with Barking and Dagenham, where you live until 58 before you have your first major health condition. Similarly, for women, you see the difference between Wandsworth and Tower Hamlets in London. The inequalities are a key part of our experience in this city, and it's often an invisible part of our experience in this city. It's caused by a number of factors. High levels of smoking across the city, rates of smoking are declining, but the differences between more affluent and less affluent parts of the country are significant. And smoking is one of the major causes, not only of early death and mortality, but it's also a driver of the inequalities that people experience. We also see significant differences in the city in who gets screened for cancer. So you can imagine, if you're again living in some of the more deprived parts of the city, more disadvantaged parts of the city, your cancer screening rates, and this is despite offering cancer screening to everybody in the neighborhood, you have significantly lower cancer screening rates. We identify your cancers later, and therefore you have a lower life expectancy. Obesity is completely socially patterned. Although we have high prevalence across the entire city, if you live in more deprived parts of the city, again, higher rates of obesity that results in heart disease, strokes, as well as premature death. And you can imagine if you begin combining all of these conditions together, that further increases your chance of developing early disease and dying early. Mental health issues are also socially and economically patterned. The more poor you are, the stressful conditions that you're living on, the more you're likely to have mental health issues, and the less likely you are to be able to access services to help with your mental health. And we see significant differences across ethnic groups in mental illness in our city. Now, I don't have to tell you all about air pollution because it's a big deal for us in the city. And we know that, again, if you're in poor parts of the city, living beside major causeways, you're much more likely to be exposed to toxic air. And that toxic air can result in dementia, in heart disease, a range of health conditions that are affecting us as Londoners. And finally, chronic diseases such as hypertension, diabetes are all socially and economically patterned, and we see significant differences across racial and ethnic groups. So this, in a sense, is the background picture to London. And as the public health director, these are the things that would keep me up at night. These are the things that would work with our partners to say, how are we going to deal with this and what are we going to do differently in order to help all Londoners be much more healthy? And the reality is that these inequalities that I've described do not have to be that way, right? There's nothing in these data which are inevitable. There's nothing that is permanent. There's nothing that is a given. However, this is the reality that we're working in, and this is the level of honesty that we need as Londoners to be able to address it. So it's Martin Luther King who said, of all the forms of inequality, injustice in healthcare is the most shocking and the most inhuman. Let's not let these data be background noise for us in the city. Let's never let these data be business as usual. We can and we must change it. So, one of the ways that we're going to change it is by thinking differently about how we provide services and how we begin to tailor services for those who are in greatest need. And I have a little demonstration for you. So I'm going to ask two of my colleagues to join me now, because what we're going to do is to imagine a country or an environment where the thing that's valued most is height. And there are three of us here in a society. And you can see that there are some natural advantages that one of us has, right? And this often happens in society. The things that are valued, whether your race or your gender, your sexual orientation, can give you natural advantages. Now, there's a way in which we can help to improve everyone. And if you think of this line as the barriers to accessing health and accessing the great things in life, you can see, if we hold it up a little higher, thank you, that I have absolutely no problem looking over the barrier, and therefore I can enjoy the full benefits that society has to offer in terms of health and generating wealth and improving my health outcomes. Unfortunately for my colleagues, you can see they're below the barrier in a society that values height, and they're not able to do so. Now, the classic thing that we tend to do is to say, let's treat everybody equally. Let's give universal healthcare, universal education, universal screening for cancer, which is a good thing. Don't leave the lecture and think it's not a good thing. Let's see, when we're all treated the same, what happens. Two of us now are able to access health and really benefit from what the society has to offer, but we're still leaving someone behind. We're still leaving someone behind. So, we're being treated equally here, and this is what equality is about. That irrespective of your background, your natural advantages, you're able to, some of us anyway, able to participate fully in society. Now, there's a way in which we can deal with this. If we step back, and that's by thinking differently about how we give a little bit more to those of us who are more disadvantaged, who start life having no choice in their height, so to speak. But to be able to say, actually, we're all starting in different places, and sometimes we just need just a little bit of help to get to a different place. So let's see when we apply an equitable solution. That's right. Now we can all participate in health, and we can all begin to understand and to be part of creating a healthier and wealthier society. Thank you so much. So that's the first takeaway, that equality matters, but for improving health, equity is really, really important. And for my NHS colleagues here in the room, they know. We speak about this all the time. Let's deliver cancer screening services, but let's go further to see what we need to do for people who don't speak English, who live in the poor parts of the city, who are not engaging with our treatment services, because that's what we need to do to ensure every Londoner is reached and no one is left behind. So, on that background, I've told you about the story of London, in a sense, what happened pre-pandemic. A city of riches, but a city of two tales, right? Poverty, living cheek by jowl with wealth, and inequalities which are rife within our city. So these long-standing health inequalities have, in fact, been worsened by the COVID-19 pandemic. And what I wanted to do is just to share a number of key areas that we learned as we went through the pandemic. in terms of how the pandemic itself manifested itself and what we began to see as we went through the pandemic. So I've already spoken about some of the inequalities that we see on COVID-19, in general in our society. But prior to the pandemic, this slide just highlights a number of the inequalities that we were working on and grappling with. So whether it is differences in maternal health outcomes, that's been in the newspaper a lot recently, that Black mothers tend to have higher levels of maternal death and ill health, compared to other ethnic groups. We know that there are significant differences in heart disease, diabetes, and hypertension across racial and ethnic groups. And there are many other indicators which are on the slide which really highlight the differences that existed pre-pandemic. Now, in the first wave of COVID-19, we began to see how the epidemic began to manifest itself in different sectors of the population. And many of you may be aware of this because do you remember in March, April, May of 2020, I think those images are still seared into my brain, when the BBC or Sky News would reflect on the people who are dying from the pandemic. You remember those pictures on TV? Overwhelmingly, they were older, and overwhelmingly, they were brown or Black people. Overwhelmingly, there were healthcare workers who were passing away in those early stages of the infection. We did some early work in the pandemic to characterize what are some of the risks for acquiring COVID-19 and what were some of the factors which were driving who got severely unwell and who died from the infection. This slide just shows that the older you were, whether man or woman, you're far more likely to be diagnosed with COVID-19 in the first wave of the pandemic. So age became a significant risk factor, both for diagnosis and severe disease. In the first wave of the pandemic, we saw significant differences across racial and ethnic groups. And people from Black British backgrounds and Asian British backgrounds had higher levels of diagnoses, severe disease, and higher risk of dying from the infection. We also saw significant differences by deprivation status, so where you were living and the levels of deprivation in your area of residence. And this slide shows that the likelihood of being diagnosed with COVID-19 in that first wave was significantly higher for men and women if you lived in more deprived parts of the city compared to more affluent parts of the city. And when you looked at deprivation and mortality, so who actually died, at the top of that chart on the right-hand side, you see death rates in the most deprived parts of the city. At the lower end of that chart on the right side are death rates in the more affluent parts of the city. Your likelihood of dying from COVID in wave 1 was directly associated with whether you were coming from a more deprived part of the city. And if you were a man in a more deprived part of the city, your risk of dying was significantly higher. So these disparities in risks and outcome were really apparent from the first wave of the pandemic. And if we fast forward 2 years later and we looked at all of the deaths that occurred in the pandemic, you see that difference across racial and ethnic group persisted. And here are some of the data, which we won't have time to look at in detail tonight, but it's just the data behind the bar charts that show the rates of death across racial and ethnic groups were significantly different 2 years after we went through the pandemic. These inequalities were persistent and they're pervasive, and they're a key characteristic of the pandemic. But there are also other manifestations of the pandemic as well. This is looking at the geographic distribution of who died from COVID-19 throughout the course of the pandemic, looking at the entire 2-year period of the most acute phase of the pandemic. And you'd think that as a city, we would be equally affected by death and equally affected by COVID. And I've only shown the mortality statistic here, and you can see that in some parts of the city, we saw significantly higher rates of death than others, in part a reflection of demographic differences and demographic changes in the city. And the final manifestation of this, and this slide will appeal to some of the geeks in the room, but it really shows that the inequalities were not only in who got diagnosed and who died from the disease, but your likelihood of remaining unvaccinated from COVID. This slide on the right shows how that likelihood of remaining unvaccinated declined over time, and it looks at it across different racial and ethnic groups in the city. If you're a white British Londoner, you had the greatest likelihood of being vaccinated, getting 2 vaccines throughout the course of the first 2 to 3 years of the pandemic. And as you look across different racial and ethnic groups, you began to see differential uptake of the vaccine. And this was despite, for some of the groups that were most affected by the pandemic, we saw some of the lowest levels of vaccine uptake. And this comes back to the point that was made earlier by this gentleman here about what sources of information people had, how did people experience the pandemic, was there trust in the message, in the messengers, and how people were engaged as they went through the pandemic. So, just to bring it all together in terms of what we saw over the past 3 years, we had more than 3 million people who were diagnosed with COVID-19. Remember, I started by saying there are 9 million people in London? So nearly a third of Londoners were diagnosed with COVID. And these are people who are diagnosed and notified. There are many more who were exposed to the virus. You can see more than 20 million people in England being affected. Here are the deaths from COVID. Nearly 20,000 people perished as a result of our experience in the pandemic. And certainly we see a significant amount of deaths in hospitals around the city. Vaccination rates and vaccination uptake here, one of the success stories in London, despite seeing some of the differences and variations that we saw by race, ethnicity, by where you lived in the city, by economic background and status. We still managed to vaccinate quite a large number of Londoners. And this, I think, is one of the public health success stories of the city. But let's focus again on inequalities, because this is going to set us up to the third stage of the lecture, but also the second key lesson that we're going to be pulling out here. So I mentioned these inequalities that we saw in the city, and they occurred across age, across gender, area of residence, your socioeconomic status. Why did we see these differences? What was driving these differences? And how do we ever begin to correct this? We learned a lot in our work on COVID. We learned that if you lived in overcrowded or multi-generational households, you're far more likely to be diagnosed with COVID and far more likely to get severe disease. And that perhaps reflects the level of exposure, concentration in a crowded home, and your likelihood of transmitting the infection. We learned that if you were in jobs that face the public, like bus drivers, people who worked in public transportation, receptionists, even if you weren't dealing with COVID-positive patients, just by virtue of being in a public environment and being exposed to lots of people, you're more likely to be diagnosed with the disease. And certainly, if you worked in a hospital setting, the closer you were to people who had acute disease, the more likely you were to acquire COVID if you weren't wearing the sufficient protective equipment. I've already mentioned the link between COVID diagnosis and death rates and deprivation in the city, and that certainly was a key part of what we saw. And what we also saw, and this came out in a lot of the sociological work that we did in waves 1 and waves 2 of the pandemic, that if there was low trust, both at the individual level and in communities, then people did not want to engage. People didn't have confidence in the message, and they were less likely to take some of the protective measures that were being proposed, whether it was staying at home, whether it was not having people over. There were so many things that if there was stigma, low trust, or low confidence, that you were less likely to get involved with. And then the fifth thing that our sociological studies showed was that the impact of long-standing structural disadvantage, racism, and discrimination really influenced how people engaged with the system and how people trusted the system. And this, I think, is one of the key lessons from the pandemic. So, the next quote is about and from one of my other public health heroes, who is Kamara Jones. She is a fantastic lecturer on race and health. And in doing the work on the pandemic, we had to ask ourselves, how was structural racism driving the differences that we were seeing? And what could we do about it here in London? Now, there are many definitions of racism and structural racism, but this, I think, is the one that appeals to me and connects with me the best. It says that racism is a system of structuring opportunity and assigning value based on the social interpretation of how one looks, right? It's a social interpretation because the value that we put on different races and ethnic groups here in the UK are very different to what would happen in Thailand or what would happen in Jamaica or Colombia, right? So it's your social interpretation of how one looks. And that assigning of value unfairly disadvantages some individuals and communities and unfairly advantages other individuals and communities. But most importantly, it saps the strength of the whole society through the waste of human resources. Racism doesn't just affect the individual, it affects all of us. And it saps the strength of our society and wastes human resources. Let me show you how it operated during the COVID pandemic. Because it's one thing to think of this theoretically, but when you see it unfolding almost in real time as we were working on the pandemic, it's a very different thing. So, structural racism can affect how people access care, because if a healthcare system is not oriented to be culturally competent, providing information in the right languages, using images that relate to communities, that is not providing an inviting or creating a hostile environment for people, they won't use it. They won't trust it. And you have those inequalities. We now know that structural racism and the way in which we assign value to each other based on how we look not only affects how people experience services, but the quality of care that they receive. And I know that's painful to hear, but unless we are honest about it, we won't be able to fix it. There's no robust data that says if you're Black and attending accident and emergency and in need of painkillers, you're more likely to get weaker painkillers or to have your request denied. And that happens for Blacks, for Asians, people of color. Why? Because of the implicit bias by our healthcare colleagues in thinking, oh, that person is probably playing up their pain, or assuming that actually you can't be in pain, you're so big and strong, you're okay, right? That's just an example of biases in clinical decision-making, and there are many more, and I'm sure many of my clinical colleagues here will speak about this. All of this results in inequalities in patient outcomes because people aren't accessing the services, and when they finally get in the services, they're treated differently. You can imagine that results in differential outcomes. So all of the things I showed earlier in terms of differences in heart disease, in mental health issues, etc., will have a part of this. Many of you have heard about the differences that structural racism will have on who's in the workforce and the opportunities that Black, minority, and ethnic staff have to hold positions of authority within the workforce, their experience of harassment and bullying, their opportunities for being promoted. That sort of tap on the shoulder that says, actually, we'd like you to come work with us. Many of our Black and minority ethnic staff don't have those opportunities, and that's how structural racism might operate here. And finally, we also learned in the pandemic that the lack of diversity in clinical trials means that oftentimes, and we saw this in the COVID vaccination studies, and communities said, how many Black people were in that study? Why should I trust this vaccine if there were no Black people or brown people in this study, right? So people began saying, who are these clinical trials for, and why have my people not been engaged in this? There are systematic reasons why we exclude people of color, where we exclude women from many of our clinical trials, and yet try to apply the results of those trials to everyone. So, bringing this down to sort of land the point, in the pandemic, there were real pathways that exposed themselves in how poverty and discrimination really exacerbated the experience of COVID-19. Clearly, if you're living in an environment where structural racism is limiting your chances both for economic opportunities and for health, you're going more likely to be living in poverty, and that poverty, that social exclusion and economic disadvantage, had a material impact on your ability to be having long-term conditions with increased your risk of acquiring COVID. It probably affected the ways in which you were able to access healthcare. It affected the quality of the care you received. And other sort of risks that you may have experienced. And those factors work together to increase your risk of acquiring COVID or dying from COVID-19. So now the science has caught up with our lived experience. So this is not conjecture. It's not politics. It's not talking about something that, I would like to push an agenda on. We now have robust science and robust studies, which really now have defined the pathway for how this works. So the second takeaway tonight is that health inequalities are pervasive, they're persistent, and they have been exacerbated by COVID-19. So my team knows that I say this all the time. When we know better, we must do better. When we know better, we must do better. And COVID-19 has taught us, and now we know better. And so let's look at how we do better towards building a much more holistic and a more comprehensive approach to tackling racial and ethnic health disparities. Because what the pandemic has done is to open our eyes and to allow us to have a far more honest conversation about those social and structural drivers of disadvantage within our society, and allows us a choice. And that choice is, are we going to see the data and let it go? Are we going to see the data and act? Are we going to see the data and make a difference? Well, I'm really pleased that our colleagues working in the health and care system in London have decided that they're going to see the data and they're going to make a difference. They're going to see the data and make a difference. On this slide, I highlight some of the key lessons from the pandemic, which I hope will be legacies of the pandemic. And it's really important. We started this lecture today with reflection of learning and committing ourselves and understanding how we've changed. So here are 5 key things which I think are really important for us now, right? So if you want to come to any place and say, listen, I'm really interested in being part of tackling racial and ethnic disparities and really tackling the structural disparities, here are 5 things. And then there's a 6th one, which I've saved for the next slide, so stay with me on this one. But the 5 things: ensure, number 1, that you have well-resourced, equity-focused public health, healthcare, and pandemic preparedness programs. In other words, you have to ensure that the services that are going to be delivered that will provide an equal opportunity for people are also equitable as well. And that may mean that rather than distributing the resources equally across your neighborhood or equally across your borough, we think about where is the need greatest and how do we invest to help people to meet those needs. It may mean making difficult choices. And it isn't that there are winners and losers into this, but it means that we design services not with equity at the end of the service, but we think, actually, we're going to design the service, for example, let's do cancer screening. So we're going to design a new cancer screening program for breast cancer screening. And we know that we have differential rates across the city. So rather than saying, actually, we're going to design the cancer screening program, we're going to I live in Lambeth, so let's use Lambeth as an example. So we're going to put it in Waterloo, and everybody in Lambeth comes to Waterloo because it works for us as a healthcare system. We already have a building there. Let's do the breast screening there. An equity-focused way of developing your system is to say, actually, where is the need greatest? It might be in Brixton, it might be in Camberwell. Let's think about building it there, and let's think of equity from the beginning. Because if we build it for the needs of those who are most disadvantaged, you automatically build it for everyone else. If you build systems with an equity lens, everybody benefits. And that takes discipline, and it needs challenge for us not to do things the way we've always done. The second lesson and legacy from the pandemic is the need for stronger, innovative, much more agile health care and community partnerships. We worked together for 2 years in the acute phase of the pandemic in ways that I think the system has never worked together before. We were able to say, how do we develop and deliver a vaccination site in the middle of a community, working with the local imam, getting buses from local community organizations, getting volunteers from local communities to make a difference. We have seen the power of partnerships through this pandemic in ways that we could never imagine. And that has to be a legacy arising from the pandemic. We saw the importance of really timely clinical and programmatic data and metrics. I often tell this story, and my colleague Martin McRae is in the room, and Martin and I were two of the colleagues who led the NHS London briefings on COVID-19 and discussions on what the NHS was doing and what public health was doing in the pandemic. And Martin, I think you'll agree that there were times in the pandemic where we could get the data on what was happening with infections, what was happening with vaccinations, the assets that we had in those communities, and how we're going to pull them together. Data, the power of real-time data to make differences, was absolutely wonderful and a key part of how we got through the pandemic. We learned about different kinds of research that was necessary, and you've heard me present this today. Not just quantitative or statistical data, but listening to people's stories and understanding narratives and understanding feelings and emotions and bringing that to the table of how we made decisions because we wanted to make decisions differently for communities. And finally, we couldn't have done this without our communities. We couldn't have had done it without the mobilization of our communities and the strength of our communities. And the communities helped us and challenged us. We had some tough meetings. You know, Martin, myself, Paul, we had some tough meetings throughout the course of the pandemic, in part because people were challenging us. You know, you haven't come and spoken to us before. You haven't engaged with us on our health and well-being. Why are you coming now to talk to us about a vaccine? When we take the vaccine, are you going to leave us behind? Will you still be here when I have that vaccine? Why should I trust you? We could not have done this without community leaders who stepped forward, without faith leaders who stepped forward, without business leaders who stepped forward and said, we will be part of the solution and we will help you, the health service, to get through this. And that's exactly what we need to do to get through the pandemic. 5 lessons from the pandemic. These are my lessons. And I'm hoping that these are lessons that resonate with you. For those of us working in the health and care system, I hope they resonate with you as well. Now, this is the 6th lesson that I promised. And this is what I hope is going to be an exciting legacy of what we do in London and what we do differently from anywhere else in the country. Because we know better and we're going to do better. And a key lesson from the pandemic is that the pandemic really laid bare how the structural inequalities, structural discrimination were a key part of how people experienced the pandemic and had the outcomes. And our health and care system leaders in London are now saying, we are standing up, we're going to name this, and we're going to be part of the change on tackling these racial and ethnic health disparities, and we're going to integrate tackling inequalities as part of this. And part of that is starting with a place of honesty, recognizing that structural racism manifests itself not just in the police, not just in the fire, it's in our institutions. And the sooner that we can be honest about it means the sooner we can begin to address it, and the sooner we begin to think about doing this differently. So here's a framework that we've been developing in London, and I'm really pleased to say that health and care system leaders in London are doing phenomenal work in this place. Local authorities have come out strongly in being anti-racist and really thinking about their policies. NHS systems are now adopting structural approaches to and systematic approaches to tackling inequalities. This matters because this is part of organizational change to work differently to achieve different outcomes. It requires visible leadership that commits to anti-racism, that talks about, in this place, we will not be sexist, we will not be homophobic, and we're not going to be racist. That's it. Strong leadership that says we are going to create the environment here for everyone to thrive and for everyone to be able to achieve their best. It's about thinking about how we support the workforce, integrating our work with equality, diversity, and inclusion, looking at our staff data, looking at what our staff are saying, not only about their outcomes, but about their experiences, and working together to address that in a much more structured way than we have been before. It's about developing new programs. programs through an equity lens that says, actually, we're not going to, and a great example of this is the work that we're doing on vaccinations for childhood vaccinations in the city. We now have a COVID legacy and equity vaccination program that says, we learned so much in delivering our vaccination programs for COVID. How can we apply those methodologies to help us to do better for childhood vaccines so that we can get all kids in London to be vaccinated? Those are equity-focused programs and a new way of doing business within the city, a way that says, we're not just going to do this the easy way, but we're going to design it to deal with the inequalities, because we know the inequalities are there. The fourth thing health and care systems are doing is to ensure that they leverage all of their assets to be part of the solution. Hospitals are some of the biggest employers in your neighborhood. Hospitals are some of the biggest commissioners of services in your neighborhoods. How could that really begin to change place if you began thinking differently about using that financial power, using that employment power for good? And that might mean training pathways for young people coming from more disadvantaged communities to work and get their first jobs in the NHS. It might involve starting volunteering programs in local places so you begin to help everybody to get experience to working in the health system. It could also involve paying everybody who works in your hospital the London living wage. And that economic investment, that way of thinking about your power in place, is a key part of tackling that structural disadvantage that communities have. And the fifth thing that we're asking our systems to do is to strengthen how they work with communities. And that has been such a fantastic learning from the pandemic. And that certainly is going to be a key area for us to develop moving forward. So this, colleagues, is the strategic approach to tackling racism and other forms of structural discrimination in the city. At the moment, the Mayor of London is a vocal supporter of this, and he has been wonderful in supporting the connections, not only of the anti-racism work that needs to be done in every part of the Greater London Authority, but being a clear voice for the importance of all partners in London to be part of tackling structural discrimination, including racism. The GLA has funded a new knowledge hub on anti-racism, so all of our partners in London can begin to share best and promising practices as we learn together to do things better and differently coming from the pandemic. Many of our hospital trusts or local authorities have already come out with anti-racism statements and are changing the way that they work. They're training, investing in staff, thinking about how we begin to change culture effectively and for perpetuity by doing things differently and investing in these pillars. Now, is this the answer for everything? No. But it is a start. And it is part of creating a new legacy on thinking about what we're doing in tackling racial and ethnic discrimination, and how we do that by integrating the lessons from the pandemic. So, my third and final takeaway for the evening is this: that for meaningful change, reducing racial and ethnic health disparities, we must tackle structural racism, and we must name and acknowledge these structural factors that disadvantage people and that prevent us from truly enabling every Londoner to live their best life and enjoy the best opportunities that they have. Now, the lecture wouldn't be complete if I didn't have an ask for you all. So, the question is, what can you do? So this is not just for the NHS. It's not just for local authorities. It's for you and me. And in coming to the end of the lecture, I have an ask of you, and this is really, really important, because you've chosen to be here this evening, and that says a lot. And I appreciate that. And I want you to leave here thinking, I'm going to be part of the solution, because now I understand the nature of the differences that we have in the city, and there are things that you can do individually. First, I'm asking you to say it. Really important that you name racism, that you name structural discrimination when it occurs. And you have to say the whole word. Don't be afraid. Because it is in naming it and in acknowledging it that you're able to get started on solutions. There are too many things in life that go unsaid. And we can see the impact of it. I'll always remember when I went through, I'm going to share a really personal story of my experience of bullying in the workplace. And I remember thinking, this is what it feels like to be in that environment. But then what I also recognized was everybody around me saw it happening, but nobody said anything. So, promise me you'll say it. Don't be afraid to name it. It's okay. The science is behind you, the evidence is behind you, and there are lots of people working on it, but we need to acknowledge it. See it. I want you to ask some questions, right? How is racism operating here? I showed you how, when we went through the pandemic, how structural racism affected people's experiences, their clinical decision-making, etc. Ask, how is it operating in your organization? You may not be in medicine, you may be in education. You may be in industry. How is it operating here? And whether the setting is small or large, ask those questions. And again, this framework could work in thinking about sexism in the workplace. All right? It could be around ableism in the workplace. But for structural racism, ask how it's operating here, whether you're working in environments which are big or small. And work to think about ways in which you will work together to address it. So looking at some of the targets for action and looking at your levers for intervention as well. So I want you to say it, I'm asking you to see it, and then finally, I'm asking you to act on it. Don't be an innocent bystander. Don't be a silent bystander. Organize and strategize to act. Use your individual power and your individual voice to help to do things differently. And if you're afraid to do it on your own, do things collectively, because you can. You really do have the power to make that difference. And I'm asking you today, as a result of coming through this experience, to join me in being part of acting on it as well. So, my ask for you is to say it, to see it, and to act on it. I'm going to end with my final public health hero. I know it's Michelle Obama, and you don't think of her as a public health person. That's okay. I have an open tent policy, so everybody can be a public health person, right? This speaks to me in many ways, because she says that the ultimate measure of a society is not how much wealth that it can generate, but how it treats its most vulnerable members. It's not how much wealth it can generate, and London certainly generates a lot of wealth, right? But it's about how it treats its most vulnerable members. So I'm hoping that as a result of being in this lecture today and participating and listening, that you have new insights and that you will join me in being part of understanding that inequalities matter and you have the power to change it. Inequalities matter and we have the power to change it. And one last time, we'll say the we together. Inequalities matter, and we have the power to change it. Thank you very much.